Hello, welcome to this NMC OSCE tutorial video. My name is Hannah. I'm a UK registered nurse, university lecturer, and I've been an NMC OSCE programme lead. In this video, I'm going to update you on some of the pre-operative care plan changes which have come in some of the scenarios in the NMC OSCE adult exam. On this channel, I try and share advice teaching to support you with your NMC OSCE self-study and provide you with free open access resources to support you with your NMC registration. Okay, so in this video, I'm going to look at different pre-operative care plans which you can use, the scenarios that they're applicable to, and give you a couple of examples of some pre-operative care plans which you can use as part of your study. So you've got 3 surgical API scenarios in the adult OSCE, so hernia, fallen fracture, and ectopic pregnancy. And traditionally in the past, they have been looking for specific post-operative care plans. So I know a lot of nurses who have failed care planning in the past because they've done pre-operative checklists and pre-operative preparations. And the scenario briefing is very much looking for you to do post-operative care needs. So we've traditionally done things such as maybe risk of wound infection, risk of post-operative bleeding, obviously risk of post-operative pain. However, recent changes is there's a combination or mix of scenarios now. So you could get a post-operative scenario still, or your scenario could be very much asking you for pre-operative care plans. So there is obviously a difference in the care plans we need to write. And this is why it's so important to read your scenario briefing and don't just start writing your care plans through a route memorization, because you will get caught out with this in the exam. So read that briefing carefully. Is it looking for pre-operative or is it looking for post-operative care plans? So if we look at the 3 surgical patients, so fallen fracture, so this is a patient that has had a fractured neck of femur, what are appropriate pre-operative care plans that we could use? So risk of falls is still very appropriate. This patient has got a falls history, they are obviously bedbound, and they've obviously got their fractured neck of femur, so they are still potentially at risk of falls. So a risk of falls care plan is totally fine to use. They will be at risk of pain still. So often nurses get a little bit unsure what to do, because in the assessment station, the patient with the fractured neck of femur has got very minimal pain because they've been given some analgesics prior to assessments, which is great, but they're still at risk of pain. They've got a known injury and known neck of fractured femur, which will become painful once your analgesics wear off. So as long as you are framing your your pain care plan as a risk of pain because of fractured neck of femur, this would be appropriate, and you can write a risk of pain care plan. They are definitely going to be at risk of pressure damage. This is a really good core care plan to write. This patient is going to be bedbound, and they're not going to be able to be weight bearing. They're not going to be out of bed. So they're going to be at risk of pressure damage pre-operatively. Your pre-operative patients can also be nil by mouth in preparation for theatre, so they can be at risk of dehydration. So that is a good pre-operative care plan to have written and to practice before your exam, especially if it states that they're going to be nil by mouth for theatre. Your pre-op patients may also be anxious. And we also can think about patient education for preparing them for pre and post-op care. And a lot of nurses can write, preparation for theatre checklists, which is fine. I like to focus it more on a patient-centered education and make it more nurse-based, which I'm going to do a demonstration of that in this video, and less like a pre-operative checklist, because you want to make sure you're demonstrating care planning skills and not just kind of checklist type pre-op skills. So if we looked at hernia, so again, the hernia assessment station has also brought in a new scenario as well. So you can have an elective presentation. So in your assessment station, the patient's coming in for planned hernia repair, as opposed to like an emergency presentation with the patient with their strangulated hernia, for example. So your elective patients are not going to have a huge amount of problems. They won't be in a huge amount of pain, and a lot of people wander around day to day with their hernias. They're not going to be like having nausea or vomiting, because they haven't got those complications of a strangulated acute hernia. They are not really going to be at risk of pressure damage pre-op because they're going to be up and about. They're going to have walked into preoperative theatre. So we need to think about some different potential pre-operative care plans for elective presentation of hernia. So they might be anxious for theatre as well, so that's a good care plan. I'm going to go through that one with you. They are going to be nil by mouth in preparation for theatre, so again, that risk of dehydration is appropriate. We can also do patient education around this as well for pre and post-operative care. There might be a history of smoking as well, potentially. So we could do smoking cessation care plan and supporting that patient to not smoke during that pre-operative time period as well. So you could think about that, something different. I'm sure examiners like to read different care plans as well, and not just the same ones all the time. So ectopic pregnancy, again, so they have got an actual presenting problem. So they're going to have things such as risk of dehydration. They might be nil by mouth, but also they might be not having nausea and vomiting. It's quite common with an ectopic. They will have pain, so pain will be appropriate to do. There is a risk of ectopic rupture, so we could do a very specific care plan around monitoring and, detecting ectopic rupture. And also this patient is likely to be very anxious as well. Remember, they have lost a baby with the ectopic pregnancy as well. So just some suggested care plans there. So I'm going to go through 3 examples with you. So first one is risk of dehydration. All your pre-op patients will most probably have a period of being nil by mouth. And if that is clear within your assessment briefing or part of your preparation in your assessment station, then you could write that. So also we need to keep patients nil by mouth to prevent any aspiration when they are anaesthetised. We don't keep them as nil by mouth for as many hours as we used to do in the past. The research shows we don't have to maintain long periods of being nil by mouth, but they will have a period of being nil by mouth. So the problems, I've got John is at risk of dehydration due to being nil by mouth for preparation for theatre. My aim would be to maintain a normal or equal fluid balance and prevent dehydration. Reevaluate, I might be reevaluating this every hour, because I'll be completing that fluid balance chart hourly and checking the overall fluid balance. Interventions, so I'm going to explain the plan of care, the reason for being nil by mouth, and gain consent with John. I'm going to monitor and record John's vital signs, specifically thinking about those ones that monitor and assess hemodynamic status, so capillary refill time, Pallium perfusion, as well as my full news too, as per monitoring frequency and policy. I'm going to monitor and record John's fluid input and output hourly and overall fluid balance every 24 hours. I'm going to assess John for signs of dehydration, so thinking about those specific assessment skills, so things such as dry skin, dizziness, maybe reduced urine output, dry mouth, increased tiredness. I'm going to administer any prescribed IV fluids to John and monitor for effectiveness. I'm going to escalate to doctors if John's clinical condition deteriorates. I'm going to provide John with regular mouth care. So just because I know my mouth, it can have regular mouth care to prevent the drying of the mouth and any mouth soreness. We can put in a call bell one there if we want to, and we're going to document all care to John. So I'm going to go through a patient education for theatre. Okay, this is a bit like a pre-operative preparation for theatre care plan, but I like to focus it a lot around education rather than that pre-operative checklist. So my problem is John has lack of information about surgical procedure and post-operative care as evidenced by John's questions and expressed concerns. So your patient actor may, in your assessment station, be verbalising concerns around theatre or not really unsure about what's going to happen. And you might have addressed some of those in your assessment station by telling them, but you can write a care plan about it as well. So my aim would be for John will verbalise understanding of the surgical procedure, pre-operative requirements and post-operative care within 24 hours before surgery, reducing anxiety and increasing his understanding. I've just put the 24 hours in there as an example, but if you know your patient's going to theatre in like 2 hours, 6 hours, you can obviously reduce that time frame to fit with that. When I'm going to reevaluate that, I might reevaluate that every 2 to 4 hours. Again, it depends on your time frame to theatre, but also directly before the patient goes to theatre. So I know before they go to theatre, they have got all the correct information. So what interventions can we do? So we're obviously going to explain the plan of care to John and gain consent. I want to assess John's current level of knowledge and listen to any concerns about surgery. We need to know what's most important for the patient. I'm going to explain to John the importance of being nil by mouth before surgery. I'm going to ensure that John's got all the required information to make informed consent and has consented to the operation in advance. It's very important that we make sure patients are consented. I'm going to teach John deep breathing, coughing and leg exercises to reduce any post-operative complications, so such as, lung consolidation and pneumonia, venous thrombosis or DVTs. I'm going to inform John about what to expect in the operating theatre, so things including the anaesthetic, any monitors, any IV lines, potentially any drains, dressings, for example, so he's aware of that. I'm going to provide and fit John with TED stockings, so going to provide and fit John with stockings to prevent DVT, so anti-thrombotic stockings. I'm going to educate John and support with preoperative hygiene and skin preparation to reduce the risk of infection. So normally we get patients to wash and decontaminate their skin beforehand. I'm going to encourage John to ask questions and express any feelings, and I'm going to confirm with John next of kin information and who to call in an emergency with their consent. And then another good one to do is maybe anxiety, slightly different to preoperative education. So we're focusing a bit more on actual anxiety. So maybe your patient actor was quite anxious in the assessment station. So I could put John is anxious of upcoming surgical procedure as evidenced by verbalizing fear of surgery. John will verbalize reduced anxiety, feel calmer and prepared for surgery. I might evaluate that every hour, maybe if someone's really anxious and want to be checking in on them quite regularly, and also directly before they go off to theatre. So interventions for anxiety. So I can assess John's level of anxiety and specific fears and use a hospital anxiety scale. I can provide John with clear, honest and simple explanations about surgical procedure and theatre process. I can encourage John to verbalise feelings, ask questions and express concerns. I want to offer John reassurance and use those therapeutic communication techniques, so active listening, having a calm tone, open body language. I'm going to teach John relaxation techniques such as deep breathing or offer listening to music or watching the TV, so whatever he finds relaxing. I'm going to ensure John has a calm, quiet and safe preoperative environment. I'm going to arrange for John to speak with the surgeon and the anaesthetist to ask specific surgical questions. And with John's consent, I would allow for the family to be present to offer emotional support. Just some questions there, specific things there around anxiety. So good care plan to have for all three pre-op patients as well. So just remember, so important to read your scenario briefings for all your stations. Because like I said, changes happen, quite often. They're there to keep you on your toes, to stop you from just doing general route memorization learning. So read your scenario, be really clear whether it's asking for pre-operative or post-operative care plans. So look at the time frame, look at the information you've been given in the scenario. Use any information from your assessment briefing as well. And, just when you're practicing, just make sure you can confidently write two potential pre-op care plans and post-op care plans. Hope that's been helpful. I do offer independent NMC OSCE tutoring for international nurses and maternity nurses, adult and child. Get booked up in advance, at least 3 months in advance. I need you to contact me if you're thinking about wanting tutoring. I offer one-to-one and a group online program now as well. I've also got my new comprehensive updated e-learning platform for self-study. You can also do single sessions and mock OSCEs, and so please do contact me if you want any further support. If you found this useful, helpful, please like, share and subscribe. It means a lot to me. I keep this channel paid advertising free, so I don't make any income out from it, but I do appreciate your comments and sharing this and also sharing your success.